the offices, or is it incorporated into your EHR? How is it?
So for the blood pressure cuffs, that's a very good question, and they have to be make sure that people are using it correctly. So we do have a telehealth manager and their assistant, they do work with patients and making sure that either if they're in the clinic, they're checking it properly, or if they're at home, they go home to the patient's home. In fact, I think we're starting to think that if we have more and more people on this sensor, we might just need a telehealth technologist whose job is to do this. This might be a new job description. I don't have an approval for a staff position, and I know this is being recorded, so I worry that my CEO will see it. But I think that's the future where people have, using, and again, just to give you another example, we are doing some home visit with video setting. And everything was working fine in the office. We went home and speakers stopped working. So people's, I think, if you think about it, technology-wise, I just wanted to share on it, is that people's experience with technology device has improved so much nowadays with Apple phones or what you see on TV, that they expect similar kind of user friendliness with all the sensors and devices and everything. And if we can't deliver, they are not going to your point, they're not going to use it. So I think that's important. The second is, I think, for hypertension guidelines. So we use all the departmental meetings to promote these guidelines, to say what, and we do take questions, and every specialty, involved specialties also participates in this process. But also, I think now we have it on the electronic health record. It's not like a decision support tool. That's not possible with the EHR. I wish we was, but it's a link there. So anytime, if I'm a physician, I want to see what's the guideline for hypertension, I can go and click on this, and it will show up there. So I think even though people have paper copies, you know how papers are, they all get lost. So I think it's on the EHR.
Right. Thank you.
So I wonder if Dr. Wanacott and Dr. Hooper could talk about how you're using remote monitoring for your complex patients. And Amanda, could you please get the microphone over to this table?
Well, remote monitoring is something that we're really no farther along than most of you, I don't think. Our patients are primarily relatively close to, they're spread out to some degree, but we primarily count on them to return to the clinic. There's a fair number of our clinicians who will send them out with recommendations and requests that they come back with their numbers, and when that happens, then I think they're relatively successful. We have not attacked this as a medical group to grab all this. I love the ideas that we've all shared here, and overall just being more engaged with our patients. What specifically, is there another?
Well, you could be going about hypertension control and screening in a different way. I would imagine that's a big issue for your population because it's a pretty stressful job you all are carrying.
Well, so for those who, so we engage the whole team, obviously. I mean, we, when a patient enters in, the technicians are really highly focused on what blood pressure they're getting, and in fact, they will write into the assessment portion of the note. They'll actually throw in a diagnosis of elevation of blood pressure, so that it has to be addressed by the doc, and the doc can change that, but it's thrown in there so that they have to address it. It's so easy for our providers to be seeing somebody for a completely non-related issue, and then not until the patient leaves the room that they go, oh my goodness, his blood pressure is high. I didn't even pay attention to that. So that's one thing that's kind of helped. I don't think our population overall is much different than what you all have. We have about we have about 9,000 who are, whether uniform or active in what you think of as military, but the bulk of our patients are all retirees and the same general mix, I think, that most people see.
Dr. Hooper is with UC Davis.
Our primary care network is spread around the greater Sacramento area, about 14 clinics, and then we also have hospital-based clinics where a lot of the teaching occurs. I would say that up until now there hasn't been sort of a cohesive effort towards ambulatory blood pressure monitoring, but I think in general most of the physicians that I've seen do employ use of home blood pressure cuffs. That being said, there's a P4P project that is going to get started actually fairly soon using just the wireless technology that Dr. Edmond talked about. So we're kind of hoping that'll be successful and kind of a proof of concept so that we can expand to other sites. It certainly seems like it's worked in other areas. We also, as an aside, had a major reorganization in how we are going to pay our primary care physicians this year, and quality measures have become quite important. In fact, I'm chairing a committee tomorrow that's going to be discussing that and coming up with some measures to target for improvement. And I think given the renewed interest in hypertension with the P4P measures, I think that's likely to be one of the measures that we target for improvements.
Thank you.
Just on that question, I'm just wondering, I know in the past we've done things like C-section rates and looking at that. Well, okay, but then you might be an outlier. You might fall out and be too many or too less or whatever. But then they drill down and look at your population. So you might be the high-risk OB doctor who a lot of your patients are going to be C-section. So do you do anything at all like that with the overall when you're looking at how to incentivize or how to pay your physicians, where you actually break down if they happen to have a very high-risk population?
That's obviously a really hot topic, of course, because the question is how do we incent physicians? Is it based on individual numbers? Is it based on group numbers? Is it based on specialty-wide numbers? That's all to be decided fairly soon. But you're absolutely right. If you have, for example, somebody in your clinic that is just the best diabetic doctor because they're really good, and because of that they get all the high-risk patients, and their numbers look worse than everybody else's. So you have to, I think, create a system where everybody's incented to do better. You need to eliminate those small number outliers that can be irrelevant.
So I think Harry asked me to comment on the incentive, but I think you're right. I think you're saying is a risk-adjusted incentive payment program, and I think it's really hard to do that. To your point, I think we want to reward behavior. We are always trying to say, if you improve, how can we pay for your time? And I think again, it's not as much as dollar amount. It's really the time commitment which people do. I think time is the most important thing here we have. Plus, I think as we go along, we have to look into disparities and see if some of the clinics have a little bit of higher number of that population, but they do make up on other things, and we need to provide this. We never tell people that you're alone in this. We're always trying to say you're part of the team. How can we deploy that? Having said that, there's always, everything is not perfect. We are not all, Irish tap dancers. But I think, in a way, there is a variation among, and we're trying to get the most of it.
I'd like to add a comment too. I think physicians always say, my patients are sicker, right? I think that's what your point is. And so I think that this is an issue that is facing CMS as well in terms of the, for example, the readmission reduction program that they have implemented, penalizing hospitals who have higher readmission rates. And hospitals who are serving the safety net population are complaining that the risk adjustment is not taking that into account. And so while there are issues with the measure itself, and I mean, it's not a perfect measure, I would submit that I think one way to address this might be to compare peer groups. I mean, so if you have a physician or a clinic that is serving or located in a zip code or area that has more deprivation or lower income people than others, then maybe comparing others who are located in the same, benchmarking with their peers, rather than benchmarking with another clinic that is located in a wealthy area, for example. So that is one way, I think, to address it. Yeah, let's see.
I don't disagree with anything that's been said, and I think that in terms of the issue Mary just raised, I think we're really on the cusp of starting to figure that one out and have better ways of measurement. I wanted to go back to a more basic idea that I think was raised over here, and you all may know this, but I think it's worth saying it out loud explicitly. I think, I've been doing performance measurement in one way or another for over 20 years, and we didn't know much when we started, and we know a little bit more now. But one thing that I think has become clear is there's reasons to look not just at achievement or attainment of a certain level, but at improvement, as you mentioned, whether you're talking at the individual clinician level or whether you're talking at the ACO level or the hospital level. CMS, I think, learned that in the last 5 or so years. There was a point when they weren't looking at both in a lot of their programs and now do tend to, and I would just encourage everyone to think about that because there's a variety of reasons why it makes a lot more sense to look at both of those factors and build that into whether it's an incentive or just your quality measurement strategy overall.
So do we have further questions? Yes, Martha Garrity with HealthNet.
Yeah, I just wanted to you talked about what was going on in the region, and we partnered with California Health Collaborative and Capital Health Network on a forum related to heart health and training the navigators and the ER navigators and the navigators at the CBO level on heart health awareness, on the heart health toolkit, and Jim Ellsworth's group worked really closely with us, and we got 60 of the people who are really having the direct contact with our community members to be educated. From that, I've gotten 3 FQHCs who want to train the trainer model. Actually, Joan was our speaker, and I presented my toolkit. From a health plan standpoint, Medicare with HealthNet has circulated 30,000 of the toolkits to our numerator negative members across the state. And that's a pretty significant amount of people that are going to get that one-stop kit for cardiovascular health. Within our region, the Quality Improvement Program is circulating 2,700 to 3,000 of the toolkits, mailing them out with a follow-up call from SilverLink. So that's kind of something that health plans and organizations can do, is really identify those members that are numerator negative and reach out to them, and also reach out to them with a phone call. So that's pretty exciting. I'm very excited from being the author of the toolkit that's happening.
Great, thank you. Are there other announcements that people want to make about cardiovascular disease and diabetes projects that they are undertaking? We're about to break, and I just want to make sure that any events that are coming up that you want to invite people to are announced. And please fill out your continuing medical education forms and join us again next month for UC Davis's presentation about their exciting work coming up in chronic disease management. Did you have an announcement, Neil? No? Okay, with that, I just want to thank you for being with us today. Thank our fabulous speakers. Thank you, Parag and Betsy, Susan, and Mary.